doing.
People will probably, we're going to mute everybody.
I was just going to say, and if you will please keep yourselves muted until the end when we can have all.
Oh, I muted. So what else? I muted you by accident. So yeah, just we'll have questions at the end if there's enough time, or if you have questions, just put it in the chat and I'll be looking at the chat and we'll answer the questions at the end. But we'll go through the whole presentation and save any questions, discussion at the end. So, and thank you for attending. I see people are still popping on, but we'll get started. As Ellen mentioned, I'm Kerry Stewart, and this session is presented as part of the community collaboration, which we call Sharing Knowledge and Learning between the Mark G. Loeb Center for Lifelong Learning and the Johns Hopkins Academy. The Academy consists of retired faculty from the schools of medicine, nursing, and public health who share their expertise through programs like what we're doing tonight. The Academy members also partake in any of the Learning Center's offerings. Tonight's speaker, Dr. Jordan Stewart, who's not retired, so he's not retired. He's not a member of the Academy yet, but he does have a faculty appointment at Johns Hopkins, and he is a special guest of the Academy. Dr. Jordan Stewart, who's my son, is a podiatrist specializing in the diagnosis, treatment, and prevention of foot and ankle disorders. He received his undergraduate degree from the University of Maryland in College Park and his podiatric medicine degree at Temple University School of Podiatric Medicine. He completed a 3-year podiatry residency at Mercy Medical Center and the University of Maryland School of Medicine. Jordan founded his practice, which is the Timonium Foot and Ankle Center, in 2006. He's certified by the American Board of Foot and Ankle Surgery, served as the president of the American Podiatric Medical Association. I think that was 2 years. Well, a 2-year term as president, and also a member of the National American Podiatric Medical Association. On a personal note, Jordan's a 4th generation member of Bethel and recently was the lead sponsor of Bethel's Israel Affairs Committee, We Move for Israel event, and I know several of you participated. He and his wife Stephanie were married by Dr. Mark Loeb, and their son Brennan had his bar mitzvah in 2022, and daughter Brooklyn will have her bat mitzvah in 2025, both at Bethel. The title of this presentation is Preventing and Treating Common Foot Problems. So we'll get started, and I will kind of ask some questions and we'll interact and hopefully deliver some good information about preventing and treating some of the more common foot problems. There are many, many foot problems, but we picked out a few of the more common ones. Jordan, before we get started, just tell us a little bit about your training as a podiatrist, both in podiatry school, and then during your residency.
Sure. So, a lot of people, I think, don't really understand or know the background of podiatrists. Podiatry has changed a lot in the last, 20, 25 years. We go to undergraduate school, just like everybody, college, 4 years of college, and then we go to a specialty school, similar to dentistry, medical school. There's a podiatry school, which is 4-year training. I happen to go to Temple University, and at school, we actually take identical classes to the medical students. As a matter of fact, at Temple, the medical students would take classes by the professor, and then we'd flip-flop semesters. Kind of in your 3rd and 4th years, you continue to do, medicine rotations, surgery rotations, spend time in the pharmacy learning about medications, but you also start to really become a little more hyper-focused on the foot, ankle, and the related body systems. And then after school, the residencies are now minimum of 3 years. There's some residencies that are 4 years, and there's a lot of people going on to do fellowship training beyond that. So some of the students are now doing 5 years. I would say most podiatrists are also surgically trained, not all. The training has tremendously changed over the last, probably 20 years again. And, we have some doctors that simply do what's called routine at-risk foot care, and then we have other podiatrists that are reconstructing limbs and, Charcot foot deformity, which is something that occurs from diabetes, reconstructive flat foot surgeries. I do ankle surgery, Achilles tendon surgery. So it's a slew of treatments that we can perform based on our training.
So is there much of a difference between a podiatrist, what they do, versus an orthopedic surgeon that treats foot problems? Is it?
I mean, I think that
what is the distinction?
I mean, the distinction is the degree. Orthopedic surgeons do a orthopedic surgical residency where they're spending several years. As a matter of fact, in my training, I rotated. My last year was with an orthopedic surgeon. I was solely with an orthopedic surgeon, and the orthopedic residents rotated with the doctor that I was with. And orthopods who do foot and ankle do a fellowship in foot and ankle where they spend a year. Podiatrists are doing, 3 to potentially 4 to 5 years. There's a lot of overlap, and at the end of the day, we do a lot of the same things. I think the bottom line is, you just, whenever you're picking a doctor, you want to make sure that the doctor you're seeing is well versed in the condition that you're seeing.
So
that you're being seen for.
So in today's day and age, most doctors are typically part of a bigger group. But back in 2006, you actually opened your own solo practice. Tell us about that. Why'd you make that decision, which was somewhat risky at the time? Because again, as most of us look for doctors, they're part of big groups these days. But you opened up on your own, and you're still on your own. So
yeah. So
tell us a little bit about that.
Essentially, I probably wouldn't have been on my own had the person who was offering me a contract not dropped the ball at like the 11th hour. So essentially, I was looking for different job opportunities. I actually almost moved to Annapolis. And my wife and my families are here. So, I made the decision to stay local, but I just didn't like the opportunities that were presented to me. And I figured if I'm going to work hard, I'm going to work hard for myself. And, I did it. I mean, I went from seeing maybe 3 or 4 patients a week to, depending on the day, I can see, 25 to 35 to 40 patients on Sundays. And, it took a lot of hard work. I'm not going to sit here and say it's easy. The landscape of medicine has really changed even in the short time that I've been practicing, which I say short time, it's almost 18 years now. But I've still maintained my independence. I've had some people approach me about, considering buying into my practice, but I've kind of still maintained my autonomy.
Okay. And before we get on to the main topic, just one more question about the event that we had. We moved through Israel, and we've announced the results through to the participants, and it's been on the Bethel website. It's been in a couple of local newspapers, the results, but we accumulated 8,313 miles, which resulted in $8,300 to the Associated. There were 178 participants, and the average reported among those participants was about 47 miles per person. So when this idea first came up and I approached you about it, you said yes before I even finished explaining what the event was about. So just tell us what kind of perked your interest in that.
So, in my personal life, I'm very active. I like to try to exercise as much as possible. I do some weight training. I play tennis. I ride the Peloton bike. And, one of the things I always do when I ride my Peloton bike is I'm always writing move. Because in my practice, I'm really, it's no secret that in America, we suffer from a lot of health problems, particularly related to inactivity and, struggles with being overweight or obesity. And I'm always trying to motivate patients to be active moving, whether that's walking, swimming, rowing, biking. And, when the Israel event happened, when the attacks happened, I was actually in Israel this week, 1 year ago today. I was probably
January 2023.
like literally this week, where I was standing at that border of the Gaza wall. And I remember the feeling of being so close. And it's like, God, I don't know how people live here. This is just scary. And the guy said, you're fine. And, whatever. And, I really wanted to, I had already made some contributions unrelated to this, but I wanted to make more. And I wanted to just get people to do something to maybe clear their mind, help their mental health, help their physical health, while at the same time, identifying and taking a time of the day to think of Israel. and obviously if we could raise money and, contribute to Israel.
Well, I think on behalf of everybody from our community who participated or didn't participate, I think it deserve a big thank you for being the primary sponsor of that event, which was the first time we've ever done it, and it just exceeded our expectation. We really didn't know what to expect, so whatever. If it would have been 1 mile, it would probably exceed our expectation. We weren't sure, but thank you. All right, so let's get on to the main topic tonight, which is common foot problems. I'm just going to pull up. I'm going to use some slides here. Oh. Start at the beginning, that helps. Okay. So we're going to talk about some of the common foot problems. And the first one on our list is
Stop for a second. This is playing as a slideshow. You don't want to
no,
put this as a slideshow.
I advance it myself.
Okay.
So let's start with athlete's foot. What is it? How do you prevent it? How do you treat it?
So before we go on to any of this, I just want to preface this. We tried to keep these slides somewhat
less graphic
as possible, but let's be honest, we're dealing with medical problems. So if anybody is
squeamish,
just close your eyes. But I can promise you, we'll warn you before there's some bad stuff, because there are some serious conditions that affect the foot and ankle. But a common thing that people will come in with is athlete's foot. Athlete's foot, we call it athlete's foot because commonly athlete's feet are sweaty and wet. And fungus, athlete's foot is nothing more than a fancy way of saying a fungal skin infection of the foot. Fungal infections of the foot are caused by certain organisms, and they can create these little cracks in the skin, and they can cause what's called interdigital. Interdigital means between the toes, and this is an area where the skin kind of rubs together, and these fungal infections can occur. The other types of infections, and I'm going to come back to this slide in a second, are more of these are more. I'm sorry, we're trying to advance a slide. Are more of these different type of fungal infections, which is kind of more this widespread. We call this a moccasin tinnipetus or athlete's foot. The difference between the two is you can see that this skin is very dry and scaly. So this is a common problem that people have. A lot of people candidly will come in the office and they're very concerned about it. They think that they have some disease that's going to cause them serious health problems.
So it's really a local issue. It doesn't affect. You don't get sick from it.
Well, the answer is generally speaking, no. However, you can get sick from this if it's not treated. So can I move back this slide?
Let me do it.
Okay. So if you look at this first slide, this spot in between the toes, usually a very, pretty benign area. However, what frequently will happen if this is uncontrolled, and you'll see people where the in between the toes gets very white and wet. And what can happen is the skin can break, and then people can get something called a secondary bacterial infection or a condition called cellulitis. And I'm sure people have heard the term cellulitis. And cellulitis is a fancy way of saying a bacterial infection of the skin. So when people get cellulitis, that can be more of a really serious health problem, where if it's very severe, it can lead people into the hospital. It can lead people to start losing parts of their toes, their feet. That doesn't frequently happen, but it is important to treat athlete's foot, because in between the toes, if it cracks, it can really get deep into the foot. On the bottom of the foot, when it gets on the bottom of the foot, these areas can crack as well. So you really want to treat it. And the treatment's really straightforward. However, you want to treat these differently. In between the toes, you want to utilize more of a gel-based product. And on the bottom of the skin, you want to make sure that you're using something that not only gets rid of the athlete's foot, the fungal infection, but you want to use a urea-based product that eats away all this dry skin. So think of fungus as really living in two places. When your skin is very dry, it can actually live on this environment. It's given an environment to live. When the skin is very wet, it can also live in there. So it's a fine balancing act between not having your feet too wet and not having them too dry. And it's important when you take a shower to try to dry in between your toes, to just make sure you're hydrating your skin. And if you're concerned with this, you need to come in, and if it's out of control. This is also the primary reason. We didn't really spend a lot of time on this lecture talking about toenail fungus, which is a very common problem.
I was going to ask you about that. Is the fungus that people get on their toenails the same fungus as what they get on their skin?
It is exceedingly rare, like almost never, to see a patient with toenail fungus that doesn't have skin fungus. And the number one reason, and I had this happen today, that people come back all the time. I have this. People come into the office and say, I had toenail fungus and I took Lamisil, my nails got better, and then it came back. I had laser, then my nails got better, and then it came back. And the number one question I ask before I even look at their toenails is, did you use antifungal cream indefinitely? And consistently people say, no, I was never told to do that. So if you're ever treated for toenail fungus, the source of your toenail fungus is your skin fungus. And if you treat your toenail fungus successfully and fail to treat your skin,
It's going to come back.
it will come back. Almost guaranteed.
So it sounds like this involves a lot of self-care. When does someone need to see their doctor about this?
I mean, you certainly want to, if you're not sure what it is, or if you're using some over-the-counter products and it's not going away, you certainly want to come in. Certainly, if you have any of these secondary infections or there's any pain, secondary
Bleeding
infection,
between the toes?
yeah, bleeding, cracking, if you have risk factors such as, immunocompromised state, diabetes, vascular disease, you'd want to come in and have us take a look. Most of the products, that we use are pretty easy to use at home. The key is just maintenance. Just like anything, it's a habitual treatment. If you're not habitual, it's just going to.
Are there any, if someone decides to treat it in early stages by themselves, are there any over-the-counter brands?
I mean, they can just buy over-the-counter antifungals. Lamisil makes some.
And they work?
They can work. The problem a lot of times is that the dry skin component, this is the more common type, by the way, that we're showing this picture now. A lot of times the problem is the antifungal creams get rid of the fungus, but they don't get rid of the dry skin. And the dry skin is a very common environment for the fungus to continue to grow on. It's a very common problem. And a lot of people come in, by the way, if you look at your feet and they just look dry, a lot of times there's fungus on there as well.
Great. All right. So let's move on to the next topic. Well, it's actually a set of topics, and they have some interrelation between each other. So we kind of grouped them together, which are the bunions, hammer toes, corns, and blisters. So what exactly is a bunion?
Okay.
And what exactly is a hammer toe?
Right.
We have
we have a picture here, and I'm going to use my arrow, and we have this big red arrow. And if you move your, we don't have a picture of an x-ray, but underneath of here, there's a big bone. Your first metatarsal bone is the large bone, and your toe joint, the joint that they meet is your first metatarsal phalangeal joint, the first MPJ. And when this bone protrudes out on the side of the foot, that is just called a bunion. And as a matter of fact, I didn't label it, but if you look on the other side of the foot, you can have a protrusion on this side of the foot, and that's called a tailor's bunion. And the reason it's called a tailor's bunion is because back in the day, tailors used to sit cross-legged, and that bone would rub on the side of their foot. So tailor's bunion. So a bunion can truly be on either side of your foot. This is also called a bunionette. And essentially, this protrusion can become very painful. Now, a lot of people will come in the office, and it's generally familial. You'll see a lot of people, my mom had them, my grandmother had them, my grandfather had them, blah, blah, blah. And they're asymptomatic. They don't cause any pain or problems, but they can cause a lot of rubbing and irritation. Right where this arrow is, there's actually a nerve that runs right there. And when that nerve gets impinged, think of it like a sandwich. Think of your shoe like one piece of bread, your bone like another piece of bread, and the soft tissue, which is the nerve is included, it just gets squished in there, and it can cause a lot of pain and numbness in the toe. In advanced cases, and a lot of people have protrusion of the bone more so on the top of the joint, and they say, I have a bunion, when in fact they really have another condition, which I'm not going to go into the nitty-gritty details, but there's a condition called hallux limitus, or arthritis of the big toe joint, which is also very common. And that can start to transfer weight to this part of the foot. So bunions can be very benign, but they can also cause a lot of symptoms in the bunion themselves or on other parts of the foot.
So I read an article recently that sometimes what you think is a bunion, the bone protrusion, is sometimes the bursal sac is inflamed and filled up very much.
Right. So
How
basically,
do you make the distinction?
well, the distinction is a bursal sac. Literally, you will, if you put your fingers on it, you'll palpate it. You'll feel it feels like a little balloon, almost like a cyst. If anybody's ever had a cyst,
So it's fluid.
it's a fluid-filled sac. It's like a balloon. Now, I actually had a patient the other day come in, and her foot kind of looked like this, but when we took an X-ray, the bunion was really non-existent, and it was nothing more than a bursal sac. And she was very worried that she was going to have surgery. I had actually already operated on her husband, and we just took a needle and stuck it in and drained it, put a very small amount of steroid in there. And the hope is that it won't come back. It can come back. And if we end up doing bunion surgery on her in the future, we would certainly take that out.
So when does someone actually, I know you're very conservative and try to save surgery for the end, meaning the end of all the medical treatment you could do, but what are some of the treatments for bunions? And what makes you decide at what point this person actually needs surgery?
And there's multiple factors, and this statement will be very consistent with pretty much all surgeries other than, emergencies which would include infection or foreign bodies or injury. You always want to exhaust conservative care. The conservative care for bunions is obviously to avoid tight shoes, icing the joint, custom orthotics, which can modify the way we hit. You'd be surprised how many people actually get significantly better with orthotics in their shoes, particularly from bunions, because it limits the motion. I've had multiple people coming in wanting surgery, and we've put them in orthotics, and their pain has gotten better. Being realistic about the problem, not just, in my opinion, it's asinine to do surgery on someone so they can quote unquote wear a certain shoe. We have a lot of patients, particularly your younger people, who will come in asking for bunion and hammer toe surgery who don't have pain, and they just simply want to really wear a specific shoe. And anytime you operate on someone in that circumstance, you really run a risk of making it worse, and it's not worth it.
So they're doing it mainly for cosmetic purposes?
Yes, and I've seen too many patients, because there's a practitioner locally where I practice who actually has done a lot of cosmetic bunion and hammer toe surgeries, and many of these patients end up having pain that they never really started with. So you really want to make sure that you've done the conservative care. And if you end up needing surgery and you're limited and your health is reasonable, then you would proceed with surgery. Similar to that is, a different protrusion on the top of the foot is a hammer toe where the toe is bent. If you look at my finger,
we have the next picture.
Yeah, we have another picture, but if you look at my finger, we have joints in our fingers, just like in our toes. So a hammer toe literally is a bending, and the joint is prominent
And
here.
they call it a hammer toe because it looks like,
Yeah, it looks a little bit
like a hammer.
Yeah, a little bit. And I think in the next one we have, this is the fifth toe where they commonly occur. And a corn, the word corn and callus are very interchangeable terms. However, they are different. A corn usually is referred to something that happens on the top of the foot, usually over a joint. And a callus is something that happens on the bottom of the foot. Now, frequently people will come in, and this is, again, often cosmetic. There are definitely times where there's pain, and they'll say, I don't like the way this corn looks on the top of my toe. And corns on the top of the toe are because this bone is bent. So the only way to get rid of the toe, the corn, is to surgically straighten the toe. It's very easy to do that, but again, I would not do that for cosmesis.
Okay.
And then the last thing you asked about were blisters. Blisters are areas of friction. This is a blister. I'm sure we've all seen and had blisters. And there are two layers of skin. There's the epidermis and dermis. And when there's a friction area, which can happen over a bunion, it can happen over a hammer toe, it can happen from wearing new shoes, it can happen from wearing tight shoes, you can develop this fluid-filled area where there's fluid in between the epidermis and dermis, and usually we will drain these if they're not already drained on their own when they come in. Now, the thing you have to be careful with this type of stuff is this can certainly get infected. So, don't stick a needle that you put under a match or a lighter to sterilize it like we all did when we were kids, or maybe we still do. because you can definitively introduce bacteria. I've seen some horrible infections from people self-treating these, and these are real problems that actually occur.
So what's the best way to avoid blisters like this?
I
Or
mean,
any kind of blister?
I would say sometimes they're unavoidable. You know, you go skiing one day, your ski boots tight, you go wear a new shoe and it's tight. I mean, the best thing to do is just try to get fitted for shoes properly and be realistic about your foot type and visually inspect your feet. If you wear a shoe and something doesn't feel right, take it off, look at it. You don't need to be paranoid, you just need to be aware.
And what about the socks? I think the socks are also.
Socks also, I mean, if you wear socks that are super thick, you know, on one hand, they can protect it, but they can also make your shoe tight. You should try to wear socks. Socks will offer another layer of protection. And going back to socks with athlete's foot also, make sure you're changing your socks every day. I would say most people do that, but there are plenty of people, believe it or not, that don't do that, particularly children.
So, so if you had to use one word to describe the kind of shoes and socks you wear, what would you say in terms of avoiding some of these problems?
You know, I think in general,
Give us one word.
one word, comfort. You want to be comfortable. You know, I think comfort is the key. A lot of people choose to wear, you know, shoes that are flimsy and flexible. You know, I think comfort, just be comfortable, but also be sensible about, you know, what you choose.
So I asked you to give one word, but it sounds like you're describing not too tight, not too loose.
Well,
So really 6 words.
6 words.
Okay, we're good with that.
I'm not good at one word.
Anything else before we go on to the next topic?
No, I think that, you know, again, hammer toes can be treated surgically. I frequently will correct hammer toes. It's not uncommon to have a hammer toe with a bunion. But again, try to make sure you do all the conservative care first before you contemplate any sort of foot surgery. Foot surgery itself is not the hard part. It's the time off your feet. It's the recovery and remembering that your heart is all the way up here. Your foot's at the bottom of your body, and swelling is the biggest problem after foot surgery because it makes you it can adversely affect healing, it can increase the risk of infection, and it can increase it can expand the time of recovery if not well controlled, because you can't get your foot back in a shoe if your foot is swollen.
So I know you're going to talk about some other types of surgery for other conditions, but sometimes you've told me that in some patients you use a boot, in other patients, this is recovery from surgery, bunions or any type of foot surgery. Sometimes you use a cast, sometimes you use a boot. Why do you use one over the other?
So if you go back here for a second to the bunion picture, I mean, you know, some bunions are up here, only the deformity is up here. Some are all the way back here in the foot. Oh, what happened?
Let's go back.
All right. Nope. Next.
Okay.
It depends where the deformity is. So if the deformity is much further back here, you could ultimately end up needing to put someone in a cast because you need to keep them off their foot and you want to protect the foot. A lot of this is surgeon's choice and surgeon's preference, but generally speaking,
and patient compliance.
And also, you know, making sure you're picking patients who are going to be compliant. You know, if you do procedures up here, usually you can get people weight bearing a little earlier. There's a lot of people now doing minimally invasive bunion surgery. That's something I actually don't want to get into right now, but I don't actually do that because I was not trained on it. There's a big learning curve to that, but there are some minimally invasive options that have become available for bunions.
Okay, so let's move on to problem I think is very common. I know I've had it, ingrown toenails. So what's the main reason why this occurs? And then we'll talk about how you treat it.
Well, let's talk about what it is first, actually.
Yeah,
So, you know, if you look at this picture, you can see these corners of the nail. You know, just so everybody knows, I think frequently people will say ingrown nails and automatically their head goes to I have an infection. I mean, this picture actually shows some redness and swelling, and you know, obviously we can't see warmth, but it's probably warm if you were to touch it. But just to be clear, ingrown nail does not equal infection. Ingrown nail is when the nail is literally growing into the skin. And you could have an asymptomatic ingrown nail. More often than not, they cause pain, and they're usually from a nail that's kind of incurvated. Incurvated meaning it's curved. And the nail is growing into the corner, and it frequently causes pain. When that nail continues to grow into the corner enough, it will cause the skin to start to split, and then bacteria will get in. Similar to how I said, those athletes' feet can get infected. They can get an infection in the soft tissue. And when that occurs, we need to treat it. We need to treat these. It is very uncommon for patients to have significant problems, but I will tell you, I just had a girl come back. She wasn't my patient. I did not do this procedure, but she was in Florida, and I took over her care when she moved back to Maryland, who was 20 years old, went for her sophomore year of college. She ignored an ingrown toenail for 3 months, and she's now missing half of her big toe at age 20. No other health problems. I've had 2 other people in my practice who have
Because of
ignored
the infection.
because of the infection. She got what's called osteomyelitis. She got a bone infection and she had an amputation of her toe. I had a 15-year-old that happened in my practice about 10 years ago. And probably in the last 5 years, I had a 38-year-old guy. So there are people that are deathly afraid of going to the doctor for ingrown toenails, and they let these infections get bad and they literally lose parts of their toe. That is very uncommon, but it is common enough that people need to be aware about it.
How can an individual prevent it? I mean, I assume that cutting their toenails properly would be helpful, but what's the proper way to trim your nails?
I mean, you always hear people saying cut straight across, don't cut straight across, dig into the corners. I mean, to some extent, they're not preventable, meaning some people, if you continuously have a problem with an ingrown nail, you want to go get it treated. There are not many things in my practice that I would say procedures are the best option, but ingrown toenails, procedures are the best option because the recurrence rate is so high that you want to get rid of it. So when we talk about a procedure on this, when we're doing a procedure.
But before we just get to that, so would you say cutting the nail, like just follow the curve of the toe?
You can follow the curve of the toe, but when people are painful and symptomatic, they cannot get under the nail like we will with anesthesia. So, when we do these, we're numbing up the toe, we're taking out the side of the nail that's ingrown, we're removing this piece of the nail right here, and you're removing it, and then we're putting an acid back there to burn that portion of the nail so that nail doesn't grow back. Success rate of this procedure is very high. Once you're numb, it takes 5 minutes to do this. It takes 2 to 4 weeks to heal. That doesn't mean you're inactive and incapacitated. Most people are back in a shoe in a day or 2 or 3. Most people are back to doing sports pretty quickly. But you have some patients that it can take 2 to 4 weeks to heal. Sometimes they get infected after the fact. I had a guy that I did a procedure on. He came in with an infection. I cleared up the infection. Usually you want to get rid of the infection before the procedure. I did the procedure. He did great. And then he said 2 days ago it started hurting again. And now he got another infection. So they can get infected no matter how compliant or how good you are. Toes are just dirty appendages. They harbor a lot of bacteria, and people, it's not an uncommon complication of the procedure for people to get an infection.
Does the shoe you wear matter also in terms of being at risk for ingrown toenail?
Yes, I would say shoes certainly can contribute to ingrown toenails. Obviously, like bunions and hammer toes, if something's tight and pushing, you're going to get an ingrown toenail that's aggravated. It is not common to have them on other toes other than the big toe, but they do happen on other toenails. So this procedure is commonly done on big toenails. I would say a handful of times a month, or maybe even every other month, we'll do them on smaller toes. The procedure has a very high success rate. Some people just don't respond to the acid, and we have to do other procedures where we excise them. I think
But that's still done in the office.
that's all done in the office. I can think of one time where I had a patient that she kept regenerating nail no matter what we did. And we actually took her to the operating room and shaved a little piece of the bone off, because the nail actually comes off of the base of the bone. But I would not worry about that. That is so infrequent and uncommon. The key is wearing wide shoes. Don't dig at your nails. And if it starts to hurt, go see a foot doctor. If you're concerned with infection, know the signs and symptoms of infection: red, hot, swollen, pain. Pain is the biggest marker for infection. And I know this picture is a little sideways, but if you can look carefully, this patient's numb. This is our makeshift tourniquet. We put a little glove around the base of the toe, use a clamp so there's no bleeding or little to no bleeding, and we, just cut this right off.
Cut it off.
And it's straightforward and easy, and it's very, very successful procedure. And you'd be surprised how many people are deathly afraid of the procedure because it's a very anxiety-provoking procedure. And then they come back and they're like, "This is the best thing I've ever done. I've been dealing with this for 20 years. I wish I did it earlier."
I'm squinting. I'm trying to see what the writing is on the tattoo. I hope it's not the person's name and we're not violating any patient privacy.
No, we're not. She's good.
She's good to go. Okay. All right. So let's move on to a very common problem, which is plantar fasciitis. I think I spelled it wrong. I think there's two I's.
Yeah, you did spell wrong.
I just-
Fasciitis.
That's my fault. No, this slide came.
Oh, the
this way.
slide, this is a slide that we used. I'm sorry, but this is spelled wrong. It doesn't matter.
It
Let's
doesn't
keep
matter.
going.
So I know I had it, and it started out with heel pain. You know, I did a lot of running, walking, all kinds of sports. Is it inevitable? Well, first of all, explain what the plantar fascia is, and then we'll talk about like what causes the problem and then how to treat it.
So plantar fasciitis, probably one of the most common problems that we'll see in the office. It's frequently associated with being active. With that being said, it can come from other conditions. It can frequently occur from an acute injury where someone just takes a sudden step, similar to an Achilles tendon injury. You get this sudden burst. But the plantar fascia, if we look, it starts or originates on the heel bone, which is the calcaneus. It spans all the way to the ball of the foot. And I would say there's three areas where people can get pain. This is the primary area. This is kind of like the classic typical plantar fascia area. The middle, which we call the mid substance, is where people will complain of cramping and pain in the arch of their foot. And then sometimes people will get pain in what's called the distal plantar fascia, which is the end. Proximal and distal is just terms. So proximal is here, distal is here, middle is the middle. Plantar fascia is a big rubber band. So think of a rubber band. When a rubber band is relaxed, there's no tension on it. It's kind of just think of everybody picture a rubber band. When a rubber band stretches, you start getting these little tears in it. And essentially what you're getting is this repetitive tearing. It's microscopic tearing. And over time, as it continues to tear, it'll start to thicken. And not shown in this picture, there's a nerve that runs over here that frequently starts to burn. And those symptoms typically are, I get up first thing in the morning, I get up out of a chair and I can't walk. And I saw 3 cases of people just miserably limping today, where people come in and they'll just have a lot of heel pain. They often have undiagnosed tendonitis, meaning they have pain up here on the ankle that they didn't really know. And it's generally from overuse. You know, they're doing a lot of walking, they're doing a lot of running, they're doing a lot of barefoot walking. They've had a significant change in body weight. For example, pregnancy. You'll see a lot of pregnant women who will go into pregnancy at their normal weight, and then they'll gain 20, 30, 40, 50 pounds, and their foot will start hurting. So the mainstay of treating this is being sensible. I use this analogy multiple times a day, and I think it rings true to anything in life. If your head hurts and you bang your head against the wall, your head's going to hurt. If your foot, imagine your foot is your head, and the ground is the wall. If your foot is constantly pounding on the floor, if your head is constantly banging against the wall, you're going to constantly stretch this and aggravate it. Now, obviously, unlike a hand injury, it's hard to stay off the foot. You can offload your hand a lot easier than your foot. But you have to be very cognizant of conscious of your activities. If you know you're walking your dog 4 miles a day, then try not to do it. You can't do things
if you're having the pain.
If you're having the pain, if you have symptoms. You just like anything, and this holds true to anything that I treat. If you have an injury, you can't get better by doing what you want to do and expect it to get better. That's like anything in life. You're trying to lose weight, you can't eat cheesecake for every meal. It doesn't work. So the mainstays of treating this, and there's a million ways to treat this, are being sensible about your activity, stretching, icing, avoiding barefoot walking, wearing proper shoes. Medications can help. I really, in my practice, try to focus on mechanical treatments and really getting people to move, be active, which I talked about in the Move for Israel, but be active in a different way. There are plenty of, you can't imagine how many times I sit and talk to a patient about don't walk, don't do this, don't do that. And the question that they ask after everything is, can I walk? I don't know if they just chose not to hear me, didn't hear me. But nowadays we live in a time where there's so many other options. Biking is great, swimming is great, rowing is great, weight training, sitting down. Why sitting down? If you hold weight in your hands, you're increasing the load on your foot. So thinking of it as gaining weight. A lot of people aren't holding 2 or 3 pound weights. They're holding 10, 20, 30 pound weights. So that's putting an increased stress on the foot. Then we also will implement in our practice as part of the treatment, orthotics. Orthotics, people can try over-the-counter orthotics. We tend to make a lot of orthotics. This is just a demo of one variety. We make a ton of custom orthotics. Orthotics are the long-term treatment. You know, you'll see in the news, if you watch TV, the good feed stores advertising like crazy, and they're master advertisers. No one, including myself, would say, put an orthotic in your shoe and you'll be fine. Orthotics are not the primary treatment for anything. They're the long-term treatment. You have to treat these things primarily and then transition into an orthotic device. Orthotics are good at keeping people better. They're not good at getting people better. So, you know, when you try to put things in your shoes as the only treatment, as a primary treatment, don't have high expectations. So you want to really focus on addressing the anatomy. And then the last thing I'll say about plantar fasciitis, which we could talk about forever, you don't want to overstretch. I think just like a scab, if you keep picking at a scab, it's not going to heal. You have a lot of patients come in and they come in with 25 devices that they bought on TikTok and Amazon Dr. Amazon, Dr. Google. And, you know, they're massaging it and they're kneading it and they're putting a dough roller on their foot and they're, you know, driving balls and magnets in their feet. Less is better sometimes. I find that patients who come in and they're just not getting better, I tell them to think of their foot like an overheated car engine. Just shut it down and rest. And a lot of times you just have to commit to a treatment that you're going to be off your foot for a period of time and get better. I rarely do surgery on this. Most people don't need surgery on this condition.
And is it inevitable that someone that runs a lot or walks a lot going to get this, or can they prevent it by the shoes they buy?
I don't think it's a rubber stamp guarantee that anybody's going to get it, but I will say that if you talk to the majority of people,
They'll have it.
they'll have it at some point in their life. I mean, it is very, very rare that you sit in a room with 10 people and 7 or 8 people never had it at some point. Adults, that is.
And then what about these shoes now that there's all different styles of shoes with, you know, the rocker type, the more cushioning in the heel, more cushioning up front?
I think generally speaking, I mean, this is a generalization, but you want to stay away from more flexible shoes. You want to stay away from minimalist shoes. You want to wear shoes that have a little bit more of a chunk in the bottom of them. Obviously, it's not practical to wear sneakers all the time, but one thing with COVID has made the world much more casual. And I think that you just want to get either a neutral or controlling shoe, depending if you have an orthotic in the shoe, just to really control the mechanics of the foot. But again, that's part of the treatment. You have to really treat it comprehensively. There's not a one size fits all for plantar fasciitis, and not everybody will get better from everything.
Okay. And you said one of the medical treatments though is steroid injections. Are they
steroid injections? I would say earlier in my practice, I used to give a lot of steroid injections right away. I personally focus more on, you know, mechanical treatment because that's ultimately what gets people better. The problem with giving people a steroid shot is that they feel better. And you're like, obviously I came to the doctor to feel better. But when you do something like that, people feel better and then they don't do everything else. And then 3 months later, they tend to be back to square one.
So you're masking the problem, basically.
Pretty much. And, you know, nowadays, the biggest problem that we're seeing is not problem, but we're seeing a lot of people who are addicted to pickleball, and they're coming in with a lot of plantar fascia injuries and they don't want to take the time off. And they're kind of almost asking for these injections on the spot. And I think that as a provider, you have to be very cognizant of what's in the best interest of the patient long-term, and not letting them just kind of dictate what they want, because you can do damage with steroid shots if they're not used properly.
Yeah, and like repeated steroids in short amounts of time can have an adverse effect.
Yeah, I mean, you can
on your tendons, right?
Yes, you can rupture the plantar fascia. I will say the one thing about rupturing the plantar fascia is it's not the end of the world if it happens, because essentially if you do surgery on plantar fasciitis, that's what you're doing. But the difference is when you operate on a plantar fascia, you're doing it in an operating room in a controlled environment. And when someone ruptures their plantar fascia, it can be pretty miserable. So you want to try to avoid it.
Okay, we're going to move on to the next topic, which is arthritis and gout. And we're going to discuss, Jordan will discuss these together because they're somewhat related.
Right.
So,
you know, everybody, I'm sure, has heard the term arthritis. People have heard the term rheumatoid arthritis, gouty arthritis. You know, there's a whole variety of arthritis. Osteoarthritis essentially is degenerative arthritis, normal wear and tear. I always tell people to think of 2 hard-boiled eggs. If you have a hard-boiled egg, in this analogy, the cartilage is the shell of the egg, and the egg is the bone. And basically, bones have cartilage, which as it glides against each other, protects the bone from
which is soft, spongy
tissue. It's not
Well, it's
It's softer,
softer
right?
tissue.
And it allows shock absorption. And when joints have normal cartilage rubbing against each other, it doesn't hurt. When the cartilage starts to break and wear down, you get this eggshell cracking. So you get this egg on egg or bone on bone. Osteoarthritis is just a degenerative process. Rheumatoid arthritis is an autoimmune condition. It can affect many joints throughout the body, the hands and feet, particularly the knees. And then gout is a whole nother problem where you get these uric acid crystals that build up in the joint. And gout is generally a familial problem. It's very common. You know, a lot of people worry about their diet causing it. There's definitively a dietary component to it. It's generally genetic. Renal patients, people with kidney disease can get it, and it can be very miserable. You know, generally speaking, people will get this acute onset. Like I went to bed and then I woke up and I couldn't let the sheet touch my bed and my foot's red, hot, and swollen, and I'm just in miserable pain.
We have a picture of that.
Yeah, we do have a picture of that. Actually, let me jump ahead to that real quick. We're going to come back to this picture. So some of these pictures can be a little gruesome if anybody doesn't want to look. But these are some cases of people in my office that came in with acute gout. And this one, the small toe, is actually really interesting. And this patient was actually being treated by his primary care physician for cellulitis, bacterial infection, for like a month, and he wasn't getting better. And I looked at him and, you know, I don't want to pat myself on the back, but it was pretty obvious to me that these little white dots,
I'll do it for you.
thank you, that these little white dots were sticking out of his foot. And the white dots are the telltale sign that this guy had gout, because this is actually what gout looks like when it starts to precipitate. So these gout crystals, these are called tophi, were kind of protruding out of this foot. And we sent him to the lab, and sure enough, we diagnosed the patient with gout. The patient got his gout under control with medication, and his toe is pretty much back to normal, with the exception of a little chronic swelling in the joint. The common area where we see it on the other slide is where you get this big, red, hot, swollen joint. And you want to treat gout two ways. You want to treat it acutely by getting the patient out of their miserable episode. And when I say miserable, I mean this is miserable. You wouldn't wish this on your worst enemy, or maybe certain enemies you would. But and you would want to treat this acutely. Generally speaking, we'll put people on some medications, either steroids or colchicine. If they can't tolerate those medications orally, we will stick a shot in here. I generally try to make sure the office is clear, because the screaming from this shot is not pleasant. It's usually heard down Deerco Road from my office. Once the patients are controlled, it is almost impossible to control gout with just diet. People ask to do it all the time, and they normally fail, and they normally end up on medication. And I would say it is very rare that patients have problems with the medicine for gout. So I want to go back to this and just show a picture of what a healthy joint looks like and an arthritic joint. And this is exactly what I was talking about. These are actually some pictures from my surgical procedures that I do. I take a lot of pictures in the operating room. If the picture on the left, you can see this is normal cartilage. This is nice, white, shiny cartilage. This is normal. And this one is an arthritic joint. So you see the normal cartilage here, but there's a lot of degenerative cartilage. So this is what I was talking about. Think of that eggshell cracking, and that cartilage is gone. So this is what a joint arthritis looks like. And when this other side of the joint has a similar finding, when this rubs together, people get pain. And when joints like this are painful like this, it's almost impossible to get rid of the pain without fusing the joint together. And the next picture just shows what we commonly do is we'll put a screw. A lot of times we'll use a combination of a screw and plate. Just depends on what the patient needs. This patient, we put one screw there. I did a procedure back here to get this bone down, but this is where you fuse the joint. And the reason we fuse the joint is to basically make the joint turn into one bone. So you're eliminating the arthritis.
Okay, so
that's a surgical treatment. So, you know, not everybody needs that, but if you get to the point where you're miserable and you can't walk, like the police officer I had come in today, who's been dealing with this for 6 years, this is what we end up doing.
So I remember one time I went into the operating room with you to take some photographs, and you were actually doing a procedure where you were removing a joint replacement. So why was it necessary? Why did you remove it? I thought joint replacements are one of the treatments for arthritic joints like that.
That particular case that I remember was a joint implant that another provider had put in. And I actually had put in a couple of joint implants early in my career into this joint. But unfortunately, the first big toe joint is not a big joint, and it's not a big joint proper, but it's a big weight bearing surface. And the joint implants, unfortunately, just don't work that great. They tend to stiffen up. They tend to cause people pain. And the problem is, if they don't work, they're very hard to get out. As you remember, it took me about an hour to get that thing out, and I was chiseling and sweating. And
We needed to get almost an axe.
yes, it was very hard to get out. And the implants just don't, unfortunately, tend to work. There are plenty of people that have them. I'm not going to sit here and say they're wrong, but it would not be my first preference.
I guess the knee replacement works better because it's so much bigger.
It's a bigger surface area, and
Same
there's a
with the
lot.
hip,
Yeah, correct. Let's keep going.
Okay, now this is probably a very, unfortunately, the increase in the prevalence of diabetes is almost out of control. And I guess you're seeing more and more people who have the adverse consequences of diabetes damaging their foot. So let's talk a little bit about some of the common problems
Right.
you see in people with diabetes.
So, you're right. The younger people are coming in with diabetes. It's horrible. It's again a product of our lifestyle, our diet, and it's really bad. And I used to work at the wound care center for years at GBMC Hospital. I actually haven't worked there in years, but I did more amputations than I can probably count. And it's funny, I had a nurse who used to work at the hospital come to see me today, and who works at the wound care center today. And we were just commiserating on how a lot of the patients are non-compliant. So I want to preface this talk about diabetes and the feet, that if you have diabetes, you can do fine with your feet. You can do fine with a lot of things. It's just a matter of controlling it. If you don't take care of yourself, that's when you get in trouble. So I want to be very firm. Most patients who take care of themselves don't get in this situation because we educate them. They come in, we have them call us, we make sure they know what to do. Usually, it's the patients that are just non-compliant and don't take care of themselves that end up with these problems. There's always a few people who just have crappy luck and things happen.
How often should someone with diabetes get their feet inspected by either their primary care doctor or a podiatrist?
I would say they should come to the podiatrist. Now, that's no disrespect to the primary care physician, but we look at things a little differently. I would say that once a year, bare minimum, and if they have risk factors such as peripheral vascular disease or nerve damage, or they've had wounds, definitely more frequently. And, usually every couple months we'll see patients. So, the main things that you have to worry about with diabetes are, peripheral vascular disease, which is a reduced circulation, which you have a lot of experience with, not personally from your work profession, and nerve damage. And what happens with nerves is as the blood sugar is higher and the hemoglobin A1C, which is the 3-month measure of blood sugar, is poorly controlled, people can develop nerve damage where they can't sense their feet. They get cuts, they get sores, they can't heal, and then they get infections, and that's when a lot of problems happen. And they develop ulcerations. Ulcerations are these holes in the bottom of the foot. They frequently occur on pressure areas. If you have a callus and you have neuropathy and don't feel it, that's when you can get these open cuts and sores and wounds. And the job that we do when you come in is we're cutting your nails, we're cutting your corns, we're cutting your calluses, we're checking your pulses, we're checking your sensation. And if we identify a problem, we're making sure that you're doing things to address that problem, and or you're seeing a specialist for vascular disease. If your pain is uncontrolled by medications that I might prescribe or managing your sugars, we'll work with the pain doctor to get some of that stuff under control. Simple things to do: hydrating the dry, cracked skin, visually inspecting your feet. Don't walk barefoot. Coke bottles, glass, needles, screws. These are a handful. Legos are a handful of the things that I've taken out of people's feet who had no clue that they were there. So, it's a very common problem. It's very it's very avoidable if you just take the time to take care of yourself, just like anything. This is just another picture of a diabetic foot. I'm going to warn you that some of these next ones might be a little gory. If anybody doesn't like them, turn away. This was a patient who really let his foot go. And this was a patient of mine who actually had a wound here before I saw him. He developed, he had a wound under here and under here. And I did this treatment that I do a lot in my practice where I'll put these dermal fillers, which are very neat. a lot of times these areas have no protective fat layer, and we'll put these dermal fillers, which actually plump up the area. They can be used to prevent wounds. They can be used for foot pain. And we had this guy fully healed for like 3 years. And then he ruptured his quadricep tendon, and he let his swelling, which is horribly controlled, as you can see in this picture, and his foot rubbed and created a blister and created a diabetic ulcer. Fortunately, he only lost the piece of bone under here, and we've got him healed again, and he's doing well. But I want to point out in this picture an important thing that a lot of people take for granted, which is leg swelling. Swelling of the feet is really probably one of the main things that agitated and caused this, because his shoes were super tight because of the swelling in his feet. Now, obviously, his toes were popped up and he had these bony protrusions. But I can't tell you how many people come in and they have severe uncontrolled swelling, but they don't realize that they have severe uncontrolled swelling. And they say that, well, my legs are just fat, or they always look like this, or I didn't. The way that you control swelling is compression therapy, elevation of the feet. The problem is the compliance with compression socks is poor because they're challenging to
Hard
get
to
on
get
and
on,
off.
yeah.
But at the end of the day, this is something that is limb threatening. He didn't feel this. He didn't know it was there until he had cellulitis, and we treated it.
And
that's
he didn't feel it because of his
he
next-
didn't feel it because of the next slide, which is neuropathy, which is where the problem lies with the nerves not functioning properly as a result. Now, the other big problem that people run into, and this is another patient of mine, and this patient got this because he actually came in, he has neuropathy, he came in to see me, and before this all occurred, he came in to see me because his toenail was hanging off. And when he came in, I actually just kind of helped it come off. And he had an open wound there, and I told him just to soak it in very lukewarm water. And we instructed him to make sure that he tests the water temperature with his elbow. Why his elbow? Because in neuropathy, people get numbness in their hands and their feet. Well, he comes in the next week and he goes, I don't know what happened, but my foot looks like this. And I said, well, I know what happened. You definitely burned your foot, because this is what burns look
that's
like.
from a burn.
So he goes, well, I don't know how. Comes back a week later and tells me that him and his son tested his new hot water heater, and the water was coming out at 150 degrees. I was able to,
It should ordinarily, it's around what, 120 or so in that range?
not that high.
Maybe even lower.
Yes.
But it's not 140.
Now, I will report that fortunately, I got him healed within about 9 weeks. It took me to heal these wounds, and his foot is saved and he's normal and he's fine. But this could have been devastating. So this scenario is when people put their feet in front of space heaters, people put their feet in hot water. I had another guy call me earlier in the year, last summer, excuse me, from California. He's neuropathic. He walked barefoot on a hot pool deck, burns on the bottom of his feet, similar to this. So these are real things that are easily preventable with just using some common knowledge that you get from visiting your doctor. So, peripheral vasculitis is the last thing. You do a lot of work on this. One of the things we do is a screening tool. We'll ask patients if they get pain in the back of their calves when they're walking. We'll feel their pulses. If there's any concern with cold feet, if there's any concern with lack of circulation. I had a patient today who has a blue toe. I was on the phone with the vascular doctor, so we work hand in hand with vascular doctors to get them better. And the primary treatment for this is walking and exercising.
So one of the problems with peripheral arterial disease is that it affects about 12 to 15 million people in our country alone. About 50% of it is symptom-free. So people will have these plaques in their arteries, so the blood flow to their leg and their feet is very low, but they don't feel any pain. If they do get pain, it's the cramping when they walk, goes away when they rest, etc. But as I said, about 50% is undiagnosed. And I think Jordan kind of jumped the gun on the question I was going to ask, which is, how do you typically pick this up when you screen people in a very simple way?
You ask them the questions about cramping in the back of the legs, and you palpate their pulses. You feel their pulses. You look at their pulses. So, this is a patient, this has a lot of varicose veins, prominent veins, but this is this kind of mottled appearance of the skin. this browning of the skin. The browning, I will point out, if you see people with legs like this, or if your legs like this browning, that means you have swelling. Why do legs get brown? We all have seen the patient that looks like they're wearing brown socks up to their knees, but they're not wearing any socks and they're barefoot.
The other thing is loss of hair, right?
Loss of hair. But the brownness in the legs is because what color is blood? What color is blood? Red.
Red.
What causes blood to be red? Hemosiderin. Hemosiderin is what pigments the blood. This hemosiderin, when there's leg swelling, deposits itself in the legs, and it causes the legs to be brown. So this is called brawny edema, which is a browning edema. So again, this is a patient where compression socks, and if there's lack of circulation, lack of hair, we'd send them on to the vascular doctor. And the key is to have them walk. So the bottom line with diabetes is you can only do so much. You know, unfortunately, complications do happen. But again, the good news is the more you're on top of it and controlling your sugars and exercising and visually inspecting your feet, getting your eyes checked, getting your blood work to make sure your kidneys are normal, and, you know, being conscious.
So I think that's all the time we have for covering some of these topics. And I'm just showing a page from Jordan's website, and the link is at the lower right-hand corner. And each one of these blue boxes may be hard to read, but represents a different topic. The ones we cover today, as well as many other topics that you might be interested in. And if you click on any of those, you'll likely hear an explanation of what it is and a discussion of the treatment. It's really a great resource to cover a lot of things that we didn't have time to cover today.
And if anybody's interested also, you know, if you want to get more gross and gory, you can always go visit our YouTube channel. We have plenty of surgeries, procedures, and there's an explanation video in each of these boxes kind of going over the high level. So there's a lot of topics that we didn't touch.
Are these more fun to watch than the Taylor Swift YouTubes?
No, you'd be better off watching Taylor Swift.
Oh, sick. I'm sorry. Okay, so I think it's 8 o'clock. We can take a few questions. We have a few minutes, and I'll open it up to questions if people have any questions. Let me, I can, if you have a question, just unmute yourself and Jordan will be glad to answer. I'm going to stop the share. Any questions, comments?
This was very, very interesting, Jordan. Thank you very much.
No problem.
When I had plantar fasciitis, and I don't want to I could really feel the tendon tighten, that it was tightened. Stretching that does not help.
No, stretching that absolutely helps. That's the mainstay of treatment. What I was alluding to is you just have to be careful not to overstretch it. I think sometimes people get a little overzealous with stretching, and it's a fine balancing act. Again, think of it, you guys couldn't see me when I was talking because we had the screen share, but think of it like a rubber band. You know, if a rubber band is relaxed, there's no tension on it. The reason people get pain when they stand up usually is it pulls, and you get that acute pull. And then as you walk a little bit, it tends to ease up because it stretches out. So the mainstay of treatment, we have patients use night splints, which are devices that kind of stretch their feet out. We'll have them do some calf stretching. Calf stretches are very important because actually your calf musculature is one big contiguous structure with your arch of your foot. So as a matter of fact, not to get too into surgery, but a lot of surgery can actually be done by releasing some tension in the calf for patients that need it. Most patients get better with plantar fasciitis. I think that the key is that sometimes people tend to really, they want to rub a lacrosse ball or dig in there. And that's where I was kind of alluding to picking at a scab. Sometimes you can overdo it. And, you know, think of it like a bad bruise. If you keep hitting that bruise, it just precipitates.
And what is the most common type of foot situation that you see in your office? Like
Plantar fasciitis. I see a lot of plantar fasciitis. I see a lot of ankle sprains. I have a very sports medicine based practice. So, I mean, ingrown toenails, of course. I see a lot of Achilles tendonitis, a lot of forefoot pain. I mean, a little bit of, I had a cool foreign body in the office yesterday. I had a girl that got a foreign body in the middle of her foot. That took
What
about,
was it?
it was this was a girl that actually was putting a piece of plexiglass in a trash bag, and she fell, and the plexiglass went right in the middle of her foot, and she went to the emergency room, and they called me and they couldn't get it out, and it was very deep in the foot. It took me about 45 minutes to use an ultrasound, and fortunately I was able to get it out. I pulled out a big piece of the trash bag and the foreign body in the foot. So, you know, we see a lot of different things. I mean, I don't do any wound care anymore. I got to be honest with you. I mean, I do it like the patient that I showed you with the burn. To me, that's fairly straightforward, but I used to do very complicated big wounds. Yeah, the unfortunate part about that is a lot of those patients are frequent flyers and repeat offenders. And it just, candidly, it gets a little draining to just keep treating the same people who they don't comply. That's not everyone. I want to be very clear on that, but a lot of those patients that are in the wound care center, that's frequently what happens. So I just kind of had to give that up.
And so you refer them to wound care?
Yeah, I mean, I still can do a lot of wound care if I have to, but if it's something that's going to be more involved, it's also very time consuming to do wound care in your office.
Some people need a hyperbaric.
They need hyperbarics. So one of my colleagues who I used to work in the wound care center with, I work directly with him, and he'll do the wound care. You know, I used to do a lot of amputations, reconstructions. It's just, I don't have any desire to do that anymore.
Really should be done at a special center, typically in a hospital.
Yeah.
Where they have, you know, more equipment, the oxygen chambers and things like that. So
Yes.
unmute yourself, Linda. Oh. There you go.
Hi, very interesting, thank you. But a question is, I don't have gout, I hope I don't get it, but is there a diet to follow? You said that you need medication usually, but is there something like to look out for or not have, or?
So, you know, if you go online and read about it, I mean, there's a million things that can cause gout. Gout is, you know, you frequently hear the common culprits with gout are shellfish, you know, crabs, shrimp, certain gamey meats like deer meat, you know, something most of us probably are not eating, alcohol. But I'll give you an example, okay? So just to kind of think about this, just so I think everybody's clear what gout is, but I want to give this example. Think of a cup of water and a cup of salt, right? If you have a cup of water and you're dumping the salt into the water and you still have water, that means that the salt is in the solution. This is kind of a chemistry term. So if you're stirring that water, you still have water, right? Mm-hmm. If you keep pouring the salt and the water evaporates, now you have these gout crystals, which is actually, when I showed you that picture with the white protruded through, that's literally what it looks like when it builds up. That process where these crystals occur happens when the uric acid level is approximately 6.8 milligrams per deciliter. Now, interestingly, the normal lab range in most of our labs will tell you that uric acid is normal up to 8. Okay? So if you took a uric acid test and your uric acid was 7.5, you're like, oh, I'm fine, right? But in reality, people who have gout tend to get it. We try to keep it below 6. In fact, you want to keep it closer to 5. A lot of times patients who have gout will also get kidney stones. Now, you can't tell whether that kidney stone is from uric acid or not, unless that kidney stone is actually tested, you know, in a pathology lab. But the long-winded answer to your question is, a lot of patients will come in and they'll say, I want to avoid gout by not taking medicine. Some people are very anti-medicine. And candidly, in my practice, I said earlier on, there's only one thing I really push surgery on other than an emergency, which is ingrown toenails, because they don't go away, and gout. I push people to take medicine for gout. I used to not be so pushy about it, but it's almost impossible to control gout with diet. And I've been practicing long enough to know that that's true, because I have patients that refuse to take the medication in the past, and they almost always come back unless they're going to someone else. A friend of mine actually did not want to take medicine, and he because what happens is they feel better after we get it under control, and it's like it's out of sight, out of mind. It doesn't hurt, it doesn't bother me. It must be gone, it's cured. The issue is that with medication, you can really drive that number down. If you have a uric acid level of 7.5 and you said to me, Jordan, I don't want to take medicine. I have zero interest in taking medicine. I'm going to control this with drinking a lot of water and drinking whatever it is, that tart cherry that people will say, and apple cider vinegar and all this stuff.
Void fish.
The number, the lowest you can move that number is 1 point. So if you were at 7.5 and you got down to 6.5, guess what? You're still in that range where you're likely to get gout. The other problem is that gout is like a background condition. And what I mean by that is this. My personal trainer's wife, who's a nutritionist who I work a lot with, I did surgery on her. I did a fusion of her big toe joint. And she was complaining to me that she had all this hand pain, right? And when we did her surgery, we opened up her joint. And what did I see? I saw all this white, chalky, gritty material. And I'm saying to myself, I never gave her a steroid shot, which is commonly what steroids look like when you put them in a joint. She's only seen me for this condition. Maybe she has gout. I sent it to the pathology lab. She has gout. We eventually get her, because I don't treat hands, to see my friend who's a rheumatologist, treats her for the gout. Her hand pain is gone. I know I went on a big tangent to your very simple question about diet, but the answer is, I'm sharing that story about her because some people have elevated uric acids that are causing pathology and they don't even know it. So the best and most efficient and effective way to drive uric acid down is being cognizant of diet, but also probably if you're in an area where you're getting attacks or you're on the borderline and you're symptomatic, to take medication.
Are these medications generic, and are they, what are the side effects? I mean, why?
So
I know people just don't like to take pills in general, but are there any specific side effects that,
yeah.
you can get from the
So
medicines?
most people, the most common medication is allopurinol. Allopurinol is a drug that drives uric acid down. It depends on what your cause of your uric acid being elevated, but the most common drug is allopurinol.
Okay.
There's another, that's generic. There's another drug called Uloric. Uloric is a newer generation drug. That is, I don't believe that's generic at this point. It's more expensive. And then you'll see television commercials for Cristexa. Cristexa is an IV infusion medication that's used for gout, and it's actually indicated for people like that toe I showed you with the white chalky stuff, or if someone has 2 episodes of gout and they're on medication and they're controlled. So to take it a step further, Linda, there are some patients, I had one, a guy who was basically ready to chop his foot off, who kept getting pain, and I was going to do surgery on him, but I said, you know what, this just doesn't smell right. Something doesn't seem right. And he was getting uric acid levels of like 5, which shouldn't have been causing him to have gout, but he kept getting miserable pain. And I sent him to the rheumatologist, and he underwent IV Cristexa therapy. And this was like 4 years ago, and he hasn't had pain since. So there are good medical management of gout without doing surgery. I would say the biggest hurdle is getting most people to understand why they should take medication, and it's a forever medication. And I will tell you, most of the patients that have gout are men, not women. There are some women that have it, and most men are stubborn when it comes to medication, and they don't listen.
Okay, and this will just take a second.
Oh,
The
what about-
medication that you give, is this like any medication can have side effects, and it can, like, each person has a different reaction, yes. But a lot of people that I've heard that have gout, that I've talked to, say, a lot of them say that they have a big reaction from the medication. Their stomachs get very upset.
Yeah, so
that's what I said.
that is actually the only thing that I've ever heard side effect wise. Is we always do a little blood work to make sure your kidney function is normal. If you ever have any history of liver problems, you want to check that. I can honestly tell you, I prescribe a ton of allopurinol in my practice, and the only person that I've seen have a side effects is one of my cousins who comes to see me for it. It is a known side effect. I've only seen one patient have it. That's a low number. There are definitively other people that have it, but I can say confidently that it's not a common side effect that we see, but it is the most common side effect, and it usually causes diarrhea. That's usually what it
Right.
does. So
Okay.
if that's the case, you can take medication called colchicine, but colchicine, to be clear, is not actually lowering uric acid. What colchicine is doing is it's another mechanism of action, and when that gout starts to flare up, it actually decreases that inflammatory response. That actually causes a lot more stomach upset usually than allopurinol.
I see. Well, thank you. It's really very informative, and you explained everything, and thank you very much.
Thank you for coming.
Okay, any other questions? Well, thank you for attending, and we hope to bring more programs in collaboration with the Hopkins Academy in the next couple of months. So they'll be announced, and Ellen will make sure you hear about it. So thank you, Ellen.
Thank you.
Thank you, Jordan. Thank you, Carrie, so much.
Thank
So
you.
interesting. Who knew, right? Now we
So
do.
many things. So
Thanks
many
to
things
you,
can
now
happen
we
to the
know.
foot.
Oh my goodness, so nice to be with all of you tonight. Stay
All right.
warm. Don't
Yep.
look at the snow. It's not going to snow.
And don't slip on the ice and sprain your ankle.
Yes,
This
be
office
careful.
will probably be closed tomorrow.
No,
Call Jordan.
be careful. Just be careful.
I said-
Everybody,
If
have
anybody has
a
any
wonderful
questions, you can always
evening.
reach out to me directly. I'm happy to answer anything. No problem.
Thank you. Good night.
Thank you so
Bye-bye.
much. Good night, everyone.
Bye-bye.
Good night.